our patients are more educated. They're going to the internet. They're demanding answers for things.
Communication has been so shattered. Media, social media in particular, TikTok, Reddit, like all the places where people go and get their information before they come to an MD.
And how do you know when it is serious or it's just maybe a phase of life?
In my office, if you're coming in with pain, we're doing something about it.
People would come in with some of these symptoms. Labs would be drawn, checked, nothing shows anything. Oh, you're fine, it's in your head. And so what are you doing for those patients? Today's guest has built her career not just delivering babies, but delivering change in women's health. Welcome, Dr. Kameelah Phillips, a New York-based board-certified OB-GYN, founder of Kameelah Women's Health, and a nationally recognized advocate for women across every stage of life. Trained at Stanford, USC, and NYU, she brings surgical precision and a global perspective shaped by medical missions from Ghana to Haiti. But Dr. Phillips' work extends from beyond the clinic. She's a Castle Connolly top doctor, a media voice on platforms like CNN and The Drew Barrymore Show, and the author of The Empowered Hysterectomy, a groundbreaking guide helping women navigate one of the most common yet misunderstood procedures in medicine. Named to the Root 100 Most Influential African Americans, she's redefining how we talk about menopause, lactation, sexual health, and the history of gynecology itself, making spaces for women's voices where they've too often been excluded. Kameelah, I'm so excited to have.
Send that to me.
I will.
Oh my God. I'm like, that's a bad bitch. Oh, it's me.
Yes, it is.
Okay.
You know, before the neurosurgeon came in, she is this tiny. She's this tiny South Asian woman. And he goes, that's who you were just talking about? Because I did her intro before. I'm like, yeah, that's her.
Oh my gosh.
That's the neurosurgeon.
I love us.
Yeah, I love us too. I love us too. Kameelah, it's so great to have you here.
Thank you, Pammy.
I have to start with saying that we went to medical school together because there's going to
Absolutely.
be too much fun in this that people are
Absolutely.
not going to understand
I
how we
know.
know each other.
But it's been decades.
It's been decades.
It's been decades at this point. So good.
And after medical school, you went off to New York. I was in New York too, but we were both in
we
different
were
parts.
very separate.
Very
it felt
separate.
like
A world
miles apart.
Agreed. Yes. But we reconnected after, years of practicing. And I remember that you started your own practice. So tell us about that first. Tell us about why you started your own practice and how you're practicing OBGYN on your own terms with your patients.
Right. So I came out of residency tired, right? I joined a group practice because I just needed support, but not to work as hard as I was working in residency. Loved it. Knew that medicine was broken, knew I wasn't exactly living up to my potential, but loved it, and I was totally cruising. I was having kids, everything was fine. About 10 years into it, a VC company bought my practice and laid us all off. I was scheduled or I thought that I was gonna join, just a smaller, more nuclear practice with 3 men, and that fell apart very quickly. And I was like, you know what? I'm just going to do this on my own. I found a space. I got some insurance. In New York City, of all places.
Yes.
Yeah.
Where the competition and the
Is
saturation
fierce.
is a lot.
Serious. It's a lot. It is super dog eat dog. But I came to New York just maybe like you because it was one of those, if you can make it here, you can make it anywhere. And so I got that spirit back. And I opened my practice the day the mayor shut down the city for COVID.
Wow, timing.
Kept going. Timing was everything. I was so angry at God. I was angry at the universe, but timing is everything. I kept grinding and fell in love with medicine again, fell in love with patients, knew what I was doing, so I had this renewed confidence. And now we're going on 6 years.
That's amazing.
It's going on 6 years.
I love that.
Yeah.
Okay, so how has your practice evolved over the 6 years? Outside of having confidence, what have you learned that you do differently than maybe what your training taught you?
So it's so funny. We do 4 years of really hard, intense training, and I ultimately realized none of that kind of mattered until you're out in the real world doing your thing. The practice has taught me that, as I mentioned, medicine is broken, but also just communication. between doctor and patient, that has been so shattered by like media, social media in particular, TikTok, Reddit, like all the places where people go and get their information before they come to an MD.
Yes.
So it's this interaction with patients has helped me like reshift and remold confidence in the doctor-patient relationship. I realized I knew nothing about business, which is a whole thing for, I think, women in general.
Women in general, but definitely all of us in medicine.
Listen.
Which is part of the problem.
Huge problem.
Yes, we've lost kind of being the stakeholders and being at the table because we don't understand a lot of that.
Because we don't understand a lot of it.
And it plays such an important role because now our patients...
keep the lights on?
Absolutely, and our patients are more educated. They're going to the internet. They're demanding answers for things. They don't want to just be taken care of when they're sick. They want to be taken care of before that. And medicine wasn't necessarily, or at least the healthcare system we're in, wasn't necessarily designed for that. So how are you treating patients in terms of a holistic approach? Are you seeing patients from all walks of life? What is your demographic like?
So I see everyone, and I think part of that is because I'm a Black doctor. So I attract everyone. White women, South Asian, Latinas, obviously Black women, like the whole scope. And I like that a lot because I'm learning how to meet people where they are. I'm learning about cultures and like how we break down some of the things that hold us back as women, whether it's with communication, how we understand and relate to our bodies, sex, the menstrual cycle, like all those phases of life. So I attract everyone. I saw a 13-year-old today. So I see really young, which I love. It's hard. Those are some of the hardest visits because they just sit there and stare at you like, and you're trying
and you're trying to get information out of them and also use the time to educate them because you have that time with them at that point. They're listening.
They're listening. Even though they're not making eye contact, I know she's hearing what I'm saying. So I see 13-year-olds. I mean, I see 90-year-olds. It's such a crazy span of life. And I was seeing someone today, she was like, you need to stop doing OB. I need you just as a gynecologist. And that's where I am. I have pregnant people on this side of the room, menopausal people on this side of the room. So I do the lifespan.
Okay, well, let's talk about the female athlete. Let's talk about what's happening as they're, training for their sport. What's happening with their menstrual cycle? How can we help them be a little bit more aware of what's happening in their body and make sure that they're doing their sport in a healthy way?
Yeah. So the primary two things that I see with female athletes that I address a lot, eating disorders and when they lose their periods. So we call that secondary amenorrhea, or just you lost your period after having started it at a normal time. The eating disorder thing for me is really big because any type of disordered eating can really just have such an impact on your life. And you're not thinking about your bones, right? At 17, 18, 19. No.
Definitely not.
No.
That's the last thing you're thinking about.
The last thing you're thinking about. You're not thinking about your bones. You're thinking about your physique. You're thinking how to power through. You're thinking about how to stay thin, not necessarily healthy or athletic. And so the disordered eating is something that I see a lot, and having people revisit different parts of their bodies. Specifically, bone health is huge because I had a patient maybe 6 months ago break a hip. She just tripped on a New York street.
How old?
70s.
Yeah.
70s. Yeah, I don't remember exactly, but 70s.
Yeah.
So helping them realize, hey, boo, there is life after this sport that you actually need to be preparing for. So dealing a lot with disordered eating and helping them reframe food as it relates to their body and how food is nutrition and wealth and health as opposed to something that is demonized.
Okay, so what can we do as moms, as educators, as people with female athletes in our life, young female girl athletes? What can we do to see what those beginning symptoms or signs are? How are we going to have that red flag go off and be like, okay, I see something wrong here, and how do you attack it?
That's a little challenging because I'm not there with them on the daily, but what they tell me is, and what I see and kind of engage parents when they come to the visits, is the span of what disordered eating might look like. It is not what I thought it was, which was like a straight anorexia or bulimia, right? Where you're just not having any food at all, or, those Saturday morning shows where they just showed girls eating, and then it's not that. It's much more subtle. It's restricting entire groups of food. Like, I don't eat anything white, or I don't eat carbs, or
wow.
Yeah. So it can be very subtle. And so you have to look out for those subtle things. It can be skipping breakfast. It could just be as simple as skipping breakfast, because after that, you don't really see your child during the day.
So you have no idea what they're eating.
You have no idea what's going on. You have no idea what's going on. And so, at least from my perspective, one of the things that I try and instill is, I know we're all really busy during the day, but in the morning, we still eat together. We try and do at least a breakfast and a dinner together. And my kids don't know that I'm looking, but I'm like just kind of perusing that everything is on the plate. Even if they didn't eat it all, they're experimenting. We bring in lots of fruits and vegetables because you just never know what they're going to do at any particular time. So those are probably the two red flags that I would say parents should look out for.
Okay, I like that. And then the amenorrhea, the secondary amenorrhea. What is that signifying to you?
So when I have someone who's lost their period for whatever reason, obviously I got to make sure they're not pregnant, which, always is a thing in this age group. But with the athlete in particular, it's just that they are either working so hard or restricting that they've lost the estrogen balance in their body that allows them to menstruate. Helping them understand why that is important, because again, low estrogen status, I help them understand, is almost like a menopausal status. So again, has impact on your bones, has impact on your well-being. Now, a lot of people, it happens just because of birth control, things like that. So really helping them understand what their body is doing, maybe encouraging them to do less of this, more of this, paying attention to protein, paying attention to their weight in a way that's not overbearing, but using their menstrual cycle as like a vital sign is something that really resonates with them when they're going through this time of, really a lot of hormonal changes.
Yeah, absolutely. Okay, so for our female young athletes also, so they are probably very into their sport, very motivated people. Are you seeing any signs of pain, endometriosis? Are they trying to hide that? Are they coming to see their physician about that? What are you seeing with the younger girls as it pertains to that?
Yeah, pelvic pain, painful periods. I find, and this is something that I think that we have to stop doing just in general, I find that a lot of the athletes try and push through.
Yeah, because that's what they've been told, even through like an ankle sprain.
Push through, walk it off, shake it off, all of those things. And they have these, a period of about 5 to 7 days that they're bleeding, but it is an excruciating pain in a way that like an ankle isn't, or a shoulder isn't. And they don't understand it, but they have this mentality that they need to push through. And that can mean, still not missing practice, not missing school. Their self-esteem starts to take a hit because like maybe they can't push it through or tough it out. So I would say that is the one thing I see, this need to push through. And I really want to encourage them, like, you actually don't have to push through. Something might be going on. And I think pelvic pain, endometriosis, even bladder symptoms are so underdiagnosed in young people. We think it's like, oh, that's a 30-year-old thing, that's a 40. No, you can see symptoms and signs as early as, 15, 16. So encouraging them really not to suffer unnecessarily is something that we talk about a lot.
And how do you know when it is serious, or it's just maybe a phase of life, or they'll grow out of it? I mean, we hear this a lot.
All the
they'll
time.
Grow out of it. So how do you determine those things? Are you running labs? Are you getting imaging? And how are you quick to get those things?
Super quick, because I am not someone, as a woman of color who tolerates pain, right? Because our pain is so underestimated, flat out ignored, etc. In my office, if you're coming in with pain, we're doing something about it, right? Because you've probably seen
validation. But that's such great validation. I feel like that's a big problem for brown and black women, is that you're being ignored, and then when you do finally go see a doctor, it's kind of brushed off a little bit.
Absolutely.
And that's with a lot of people. I'm not just saying brown and black women, but it tends to happen at a higher frequency.
Oh, absolutely. And that's why I say people find me, because they've already seen 3, 4, 5 doctors who are like, oh, you'll grow out of it. Oh, that's normal. No, it's not. And so this is one of the reasons I like seeing 13-year-olds, right? They're just starting their period. So we're talking about what is normal, what is not. I'm like, do you get to hang out with your friends when you're on your period? No, I can't get out of bed. That's a problem.
Yes.
Really helping them understand on their level that, periods might be uncomfortable, but they shouldn't be debilitating. In your teens, 20s, 30s, you should still be going to brunch. You shouldn't be physically limited by your period. So if you can take a simple over-the-counter ibuprofen and hit the door, keep things moving, great. If you were on a bathroom floor, if you were nauseous, or you were vomiting, you aren't able to have your life, the fullness of your life, that's a problem to me.
No, that's excellent information for people to have, and also for parents to watch out for, coaches to watch out for. Tell us a little bit about birth control in those years. There's a lot of misinformation out there right now that birth control is, screwing up your cycle, may make it difficult to get pregnant later on. Give us some of the evidence and the facts behind that.
I hear birth control is screwing up your cycle, but in a way, that's what it's supposed to do.
Yes.
So I have to demystify that.
Screw it up in a good way, right?
Yeah, it screws it up in a good. That's what it's supposed to do. I hear birth control screws up your cycle, will make you infertile, decreases, I mentioned like fertility, will cause you to go crazy, will cause weight gain, God forbid we gain weight. All of those things I hear about birth control. So in addressing that, I'm always like, where did you hear that from?
Yes. Well, it's good for you to know.
It's good for me to know, because that's where I know, the Reddits, the TikToks, all of that kind of stuff. So birth control, we've gone, there are just too many studies. You don't have to study anymore. In general, pill, patch, ring are not associated with weight gain. Now, is there going to be a patient who comes in and is like, I gained this? Okay, I believe you. But in general, when you're looking at the category of estrogen, progesterone, you should not gain weight when you're on these medications. The shot, which is Depo-Provera, it's a 3-month shot, that's the exception. You can definitely see, and the studies show this, weight gain upwards of 15 pounds. And that's not insignificant when you're in your teens or you're an athlete, etc. Depo-Provera can be associated with weight gain. And so there are select people, however, who may feel that they are lower in weight than they want, who actively select that medication for the potential of that side effect. And so that's fine. But the pill, patch, ring, the implants, and the IUDs, otherwise the intrauterine devices, are not associated with weight gain. Depo-Provera, totally will admit, there's data, I see it all the time. But that's why you have to talk to your doctor about it. Yeah. That's why you have to talk to your doctor
and have
about
that communication.
And have communication and manage your expectations of what birth control can do. Have follow-up to make sure it's working for you. And if you are having side effects, we manage them.
Yeah, that's great information to have. I would like to now pivot towards the midlife woman.
Yeah.
Okay, so I'm actually, when I'm talking about midlife, I'm also talking about women that are postpartum, because a lot of us are having children a little bit later in life.
Absolutely.
So we're sort of hitting that kind of gray transitional area between being postpartum, seeing how your body is changing then, and you're also perimenopausal. Mm-hmm. Let's talk about what they're coming to you and what kind of symptoms they're having, and let's talk about it in relation to bone health and muscle as well.
So I would say my top maybe 3 perimenopausal, and you know what the thing is, they don't even use the word all the time, and I know it's such a buzzword, and there'll be times when I'm like, say it. Say it.
Own
say
it.
The word.
Own
like,
the word. Own the word.
And they'll be like, no. And I'm like, it's okay. Say it. But menstrual changes. oh my gosh, your period can be all over the place. Longer, shorter, absent, come twice a month. It can be kind of crazy, and that's due to just the sporadic ovulation we experience. So I'd say.
And what's happening with your hormones actually at that time? Is it because of loss of estrogen? Is it?
It's the inconsistent. So overall, long term, right? You're losing estrogen, but it's the inconsistency of your ovulation. Your ovaries aren't talking to each other the way they used to. Hey, I'll go. Hey, I'll go. My turn. They're just firing. Without real coordination the way we used to before. And so people see that as menstrual changes. They see that as skipping periods. Some periods come twice a month, periods that might be longer. So that's really how it presents. Okay, so menstrual changes. The other thing I see is like, so the last time I was here, I weighed 185 and now I weigh 200. What's that about? I've been working out, doing all the eating, all the things I did in my 20s.
Yeah, that does not work anymore.
Thank you. You just completed their sentence. So,
but what I hate is when the male fitness experts or sometimes the younger female fitness experts keep harping on this calories in, calories out.
That's BS.
It's total BS.
That's not how it works anymore. And I get it. I understand, like, in your 20s, how that might have worked for you. But things are
they're shifted. Hormones are shifting. Your metabolism is shifting.
Right. And in your 20s, you're not thinking about your metabolism.
No, not at all. Mm-hmm. You can just think about losing weight.
And you lose weight.
Absolutely.
Or if you're XY, you think about losing weight, and it literally happens overnight. And so this idea that our bodies stay the same is actually a complicated and challenging concept for some people to comprehend and accept.
It's the same in orthopedics when people get injured too. They don't realize they're on a new trajectory.
Oh, like I'm never supposed to get an injury?
When you injure, say, your knee or your hip, even if it's not something that requires surgery, it might not ever be the same again. Yeah. And that's a really difficult concept for people. Mm-hmm. So it's probably the same as your body changing.
It's the same. This idea that, like, oh, I'm aging. That's not cool. I don't like this process. Getting them to acknowledge, it's a process, but there are a whole bunch of stopgaps in that where you can make decisions to do this in power, in grace, screw it all, and just, go balls to the wall and do nothing. There are places at every kind of day, week, month where you have a decision.
Different junctures,
yeah. You have a decision. And the third complaint I get is sleep.
Okay.
People just aren't sleeping, and they get really miserable when they don't sleep. So if they get really miserable because they're not sleeping, then they're barking at people, and then people are like, I don't like you anymore, and then they're bickering. So, like, that lack of sleep and how it permeates their life and relationships is the third thing I would say.
Okay, and so what are you doing for those patients?
Well, I would say that at their annual, depending on how they, I would say, this. At their annual, but absolutely if I meet a woman by the age of 35.
Okay.
35, hard stop. Next time I see you, we're talking about perimenopause. My periods are regular. Okay, that's great. We're talking about perimenopause because I want to have them understand those early signs and symptoms. I want them to start to embrace this concept of being strong, building muscle, that is okay and sexy. You'll never look like Hulk Hogan unless you want to, but the importance...
That doesn't accidentally happen, by the way.
That doesn't ever happen.
So put down the small weights.
Yeah,
Lift
put
heavy.
down the small weights. Stop this, 20 rep kind of thing. And the lifestyle and dietary changes that need to happen. Your 20-year-old self is not your 30-year-old self, is not your 40, is not your 50. And so, again, it's time to give them anticipatory guidance so they can make changes. Well, and it's not like a surprise.
But that's great because I feel like for so long, people would come in with some of these symptoms. Labs would be drawn, checked, nothing shows anything. Oh, you're fine. It's in your head.
Right. Oh, I hear that all the time. But, I am over fighting people about labs. They come in, they're like, oh, I want to get my hormones checked. I just want to see where I'm off. Okay. And I go through with him why your labs are going to come back normal. Please pay the lab bill. I'm not arguing with them on your behalf because I told you they would be normal. But they just know, whatever. Sometimes people just need information to make decisions.
They do. They want the data.
They want data. And whatever, here's your data. But I help them understand why the numbers don't always matter, why we really truly practice medicine and try and treat the individual and the symptoms that come along, and the numbers will follow. That change will happen, but really I'm trying here to mitigate the symptoms you're experiencing and optimize like your health and well-being.
Okay, so labs are normal. You're going over lifestyle changes. Are there any supplements, medications, things that you're doing before labs change?
So I'm not a huge supplement person, I have to say. I do have some supplements that I like that I feel like every woman should be on. But
which ones are those?
Vitamin D, calcium. I love magnesium just because baseline, it helps calm people, let them sleep. So I would say those three.
And vitamin D and calcium need to be started super early because, again, the 70-year-old that tripped in New York and broke her hip.
Yeah, that could have been.
Yeah, that could have been prevented by taking that.
But even in our training, right, I would read, at 65, she needs to be on a calcium and vitamin D supplement. Nah, man, we missed that boat.
We missed that boat.
So my supplement is your diet.
Okay, that's great.
I'm really big, and I did it for a while. I can't say it to right now. 30 fruits and vegetables a week. That's your supplement.
Yeah.
And I literally say 30, and people's eyes get so big. It's not that hard. It's not that much. I do understand it can be a privilege depending on where you live, your socioeconomic status. I get that. But 30 fruits and vegetables, start there. Because I feel like in general, we are just moving so fast. We're so fast paced. All of us eat like crap. We just, it's hard to...
Well, it's in front of our face all the time, too.
It tastes good.
It tastes good. It's very difficult when you're on the go, busy.
You have 3 kids. Yeah. It feels good. Like, it literally... The times I eat fast food, I'm like, oh, yeah. I understand.
I get it.
Woo, that bread was good. Like, I understand, So... That's my supplement. Like, that's the only thing. 30 fruits and vegetables. Try and conquer that. Because for a lot of people, that's actually challenging.
Yeah.
To try and eat as whole as possible. Then my next thing, especially for Black and brown Caribbean patients, can we cut out some of the rice?
Okay. That's a good one. Like,
the carb load that I see in my patient population, especially in New York, is just tremendous. I married into a Caribbean family, and I remember just was me and my husband, and he brought home like a 25-pound bag of rice. Not okay, right? Not okay. So every time we meet, we're just like sort of adding on, but it's like more of a prescription, not specifically a supplement or like a new push in a holistic, plant-based, whole eating lifestyle.
I love that. And when are you giving hormone replacement therapy? Because this is very buzzy and trendy right now. Mm-hmm. And when are you deciding to do that? Or is it based on labs? Is it based on age?
Not based on labs, not based on age, because as you know now, it is so trendy. Everyone, and I'm glad it is, right? It's a conversation that needs to be had, but everyone comes in. They miss 3 nights of sleep and they're like, I'm in perimenopause.
Or you're just anxious.
Oh, yeah. Yeah. Or a project was due or so just helping them like really look at the whole picture. So it depends. I have some women as early as 45 that let's talk about hormone replacement. And none of these things, I always try and remind them, you're not married to any of this. So labs are done. They're normal. We knew that. We've changed our lifestyle. Let's talk about hormones. And I'd like to see what you're open to taking, how it's going to impact you. I go back and forth. I actually use birth control, like our traditional birth control, sometimes for a lot of women who still need it. It doesn't work for them or mitigate some of their symptoms. Hey, let's jump to menopause replacement therapy. I'm totally fine with that.
Is there a role for testosterone?
So don't get me started on testosterone.
No, because I want to know your thoughts on it.
Listen, if you don't have testosterone in your life, I don't know what you're doing. But that was not my training. And you'll see a lot of fear mongering around testosterone that bugs the crap out of me. From OBGYNs. And I get it. We see a lot of misuse / abuse of testosterones from med spas, people who may not have training in it.
Or don't follow up the labs after, know.
Yeah, follow up labs, follow up bleeding, follow up symptoms. And then those patients land on our doorstep and we're cleaning up messes. And that makes people mad. I understand that. But I love testosterone. And even when I'm starting hormone replacement therapy, typically what I do is we'll start estrogen, progesterone, if you have a uterus, at the same time. And then I tell them, hey, I'll see you back in 4 to 6 weeks. You're going to feel better. At that visit, we're adding on testosterone.
Oh,
and they're like, we are?
You prepare
and
them.
So,
I like it.
Yeah, and I kind of say it in a way like we're kind of doing it a little, big brother, big mama, I should say. But it at least gets them thinking like.
And are you telling them why you're starting it? For what parts of your body? Is it for bone? Is it for weight loss? What is it for sexual health?
You know what? I think that's the thing about testosterone that's actually kind of amazing. It's for everything.
Everything, yeah.
Like, I don't know why, even some of the organizations that I'm a part of, and I go to conferences, blah, blah, we only use testosterone if you have low libido. Really? Because I use it to jump up the stairs. Like, you know what I mean? So the way I describe testosterone is very kind of loose. I'd say I describe testosterone, and by the way, you do make testosterone, because that blows a lot of women's minds that their ovaries actually make testosterone. I describe testosterone as kind of like a everything hormone. It's going to help your bones. It'll help your muscle. It's one of those hormones that when I take, I just feel better. And that's hard to describe sometimes. Yeah. Sometimes it does help my libido. Sometimes it doesn't. But in general, with these other two, estrogen, progesterone, I feel like a better person. So I want you to have an open mind about it. We'll see what it does for you. And again, we're not married to anything. We can always drop it. But I like to put the plant in their head that like, let's talk about this. And some people come back, they do their testosterone, and they're like, my husband says thank you. My partner says thank you. Or
it's always an added benefit, right?
Always an added benefit. Or they're like, you know what? I'm doing better in the gym. And that's how I rate my testosterone. Can I get up the 86th Street train station without huffing and puffing? And so it's one of those hormones for me I love. I think women should actively use and consider. I realize we've scared the crap out of you. We told you your hair is going to fall out. You're going to get terrible acne. We told you your little clitoris is going to become a penis. We've told you all of these terrible things. Your voice is going to change. It's irreversible. I hear it and see it all. But it's actually an important hormone, and it's really not likely that those things are going to happen to you. So talk to your gynecologist about testosterone 100%.
Oh, that is great news to hear.
Yes.
Are there any regenerative therapies in OBGYN?
There are, but I haven't gotten into them.
Okay.
And I think it's interesting as I start to move away from OB and go more towards GYN, there's some gynecologists who are using PRP in the clitoral hood for sexual health, clearly aesthetics and hair. It's not something that I've done yet, but it's there and coming. And to your point, when people hear things for the first time, especially us sort of Western trained kind of medical people, we go through all this training at these prestigious institutions, and then you bring something from left field, there's a lot of suspicion, but I think that's my next stop.
Yes.
I think that's
keep an
my
open
next
mind.
Stop. Yeah, I think everyone needs to keep an open mind about everything, because the human body is amazing.
It really is.
Patients who've used PRP, I'm like, really? And even if it's only an N of 1, 2, 3, it worked for them as individuals.
Yeah.
And so you can't poo-poo that just because you don't have a randomized controlled evidence-based study. It worked for her. Like, that's real.
Yeah.
That's how I feel about it.
And it's an option. It's an option in the toolkit.
Just like testosterone.
Exactly.
It's
and
an
with
option.
PRP, it's so natural that at least, if nothing, something might not happen from it, but there's no harm.
There's no harm. There's really no downside. And that's why I'm saying, like, if it works for you, just like my patients who use supplements from like Walgreens, Rite Aid.
Yeah.
Okay, boo, if that is working for you and your hot flashes are gone and you feel fabulous, it's probably not going to harm you. Vaya con Dios.
Yeah.
Keep going with it. And I feel the same thing about these regenerative technologies. It's another tool in your toolkit.
Absolutely. Okay, Kameelah, let's talk about your book.
Ew,
Tell me,
yes.
tell me what inspired it, and how you got to writing it, and tell me how it's being received.
Yeah. So I wrote my first book.
Yes.
It's called The Empowered Hysterectomy. And one way I got to it is about 5 years ago, someone contacted me and they were like, hey, are you interested in writing a book? And I was like, no, what do I have to say? Like, who am I? I'm not an expert.
But which, by the way, I feel a lot of women I've talked to in our space, and by our space, I mean healthcare professionals on social media.
The big I.
Have that reaction.
Yeah.
Exactly. And that's so ridiculous. It's mind-blowing to me that someone like you would say that.
It's mind-blowing to me, too.
I know. It's not okay. It's not okay. Yes.
No, I can't tell you why. And I think that's what private practice did.
Yes.
It's like it ripped off that Band-Aid of imposter syndrome. And so when the person first asked me, no, I don't think so. I don't know, really. And then started my practice. When I tell you, I was meeting women 24, 34, 44 who had fibroids, endometriosis, whatever, were being recommended hysterectomy, which is to me like a sledgehammer for something that just needed a butter knife, just this little thing. Let's tweak these things. And so one day, like a 24-year-old came and she's like, my doctor told me that I have these large fibroids. I'm not going to be able to get pregnant. I should just have a hysterectomy.
Wow.
24?
First line treatment. Wow.
No, like first line treatment.
I
I was like, but boo, have you tried birth control? Have you did No, fast forward. We do blood work, we do imaging, all of this stuff. And her uterus was jacked. Like, I was mortified that at 24, her uterus had unfortunately morphed into the specimen that was compromised by fibroids. Took her through OR. We had major surgery, hospital for 2, like it was open. None of this minimally invasive.
Yeah,
it was a big surgery.
Big surgery.
She was in the hospital for 2 days, went home, recovered. When I tell you, 2 years later, she came back with her first baby.
Wow.
Yeah. Like full circle moment. Because she had such an extensive myomectomy, she did need a C-section. I took care from her from the time the stick turned until the time that little boy popped out. And so fast forward.
What an amazing story.
Crazy.
Yeah.
Crazy. Fast forward. Someone randomly called me. I was in Chicago. And she was like, hey, I saw your profile on IG. I was wondering if you'd want to talk. She asked me if I wanted to write a book. And I was like, yeah, I can do that. I'm the expert. And that's how it jumped off, really. Took me about a year to do. In the middle of the night, after the kids go to sleep, because I can't do anything while they're awake. Weekends at the coffee shop. It was a lot of like time away, missed soccer practice, which I don't think I really missed. But it was a huge investment, and it's being received so well. Someone came in, this is probably right after it was out, and it was prior to her surgery. And she's like, this was everything. This is everything I needed. This was everything I didn't know I needed to know.
That's amazing.
And I was just like, oh, this is what it's for. This is who it's for. So it's being well received. And people in Canada, like all over the place, are just
who would you recommend this book to? Is it, someone who knows they're getting a hysterectomy? Is it someone that word has kind of made its way into the conversation? Someone who's, we often talk about genetics too. Like our mothers, like did they go through menopause early? Did they have a hysterectomy?
Yeah.
Who is this for?
So actually, although it's called empowered hysterectomy, it's actually for everyone.
That's great.
So we start with the fundamentals that get women in trouble. Endometriosis, fibroids, pelvic pain, prolapse, all of those things that are like either you don't talk about, don't understand, or embarrassed to bring up. So it's a huge helpful foundation in that, almost a primer before you talk to your doctor. So you come in and like we're speaking the same language almost. And then it walks people through every iteration of possible treatment you can have, why this applies to you, why it doesn't. So again, when you're preparing and getting information, choosing doctors, etc., this is really like your guide for that. So it's not just about hysterectomy, it's like all the things in between. And if you decide that this is what you want to do, you've made an empowered, informed decision with your doctor.
I love that. That's great. So what's your second book going to be about?
I don't want to say I want to get on this perimenopause thing, but everyone is talking about menopause. It's too late by then.
Yeah.
It's too late. So I'm thinking about something that's really for like 20-year-olds from a 48-year-old. My love letter to you.
Yeah.
How to prepare your body for life. We are living longer. We're living without partners, right? We are gallivanting the world. You need to know how to prepare to do that. And it doesn't start at 48. I should have been starting 2 decades ago. So probably something in that vein.
Well, I hope you also touch on sexual health there, because I think that's something that's ignored a lot as well. Just kind of enjoying sex and feeling empowered by it, and having those conversations with young women, and kind of having them control that narrative a little bit, right?
Oh, of course. And it's interesting you mentioned that, because there's a whole chapter in the empowered hysterectomy about sex.
Oh, okay.
Yeah. Lube, toys, oral, like all of those things, because so often we tie our femininity, our worth, our enjoyment to our uterus.
Yeah.
And so if I'm telling you to take it out, or we should take it out, where does that leave? Where does that leave me sexually? So there's a whole section in the book that talks specifically about that. And I think, especially since we have so many female gynecologists now, honey, we are talking about sex in the office. I have Uber Lube sitting on the thing, and I'm like, you want to talk? This is my lube. This is what you're going to do.
Yeah.
These are the websites. I never let my kids, I try and keep them off my computer, because in the office, we're going to go to X website, and we're going to talk about dilators, and we're going to talk about rabbits, and we're going to, so I think GYNs are doing a better job about that, and it's not as taboo as it was before.
No, that's great news, because
Yeah.
I think even just maybe growing up in a South Asian household,
100%.
we didn't talk about that. And then, you get to this stage after you've had children and you're like, okay, now I feel like we've lost the moment. Like, but as you were saying earlier, we're living longer. Mm-hmm. And so we should enjoy that part of our life for longer as well.
I have 70-year-olds who have regular sex. Like, if you keep your body strong, right? If you keep your mobility.
Mobility is important.
Mobility?
Yes.
Okay, mobility. Then why can't you have sex?
Yeah.
Why can't you have sex? I have this little 70-year-old, and she's like, yeah, we still get, she calls it get it in.
Yeah.
She's like, I saw my little friend, and I'm like, I already know what that means, So I love that for her.
Yeah.
That's my grandmother in a million years would not talk about it, would not address it, or even the thought of still receiving pleasure in that day.
Yes.
So taboo.
Yes.
So taboo. And it's not just South Asian. Like, I see it from a lot of Southern transplants to New York. Yeah, we don't talk about what? You literally moved to New York to explore and have this life, but we're not talking about your sex and sexuality. It doesn't make sense to me. I have a lot of religious people.
Yes.
Religion has been a huge thing for, I think, women in terms of oppressing and suppressing their desire to be sexual. So really rewriting those narratives is so important. I have them, again, the whole dilator website. We talk about vaginismus. They see a pelvic floor specialist. I have a roster of sexual therapists to help them break down those barriers that have been the walls that have been built up after years of training. So no, it's a major endeavor to help elevate women in their sex and sexuality.
Well, there's so much attention now on women's health, so this can only be good for all of us.
For all of
us.
Yes.
Kameelah, it was so great to have you. Please let our listeners know where they can find you.
Well, I am at Kameelah Women's Health. I'm a New York-based practice, so you can find me there. The Kameelah Women's Health is the address. And on Instagram and TikTok, like everyone else, Dr. Kameelah Says on IG and TikTok.
Thank you for coming. Sorry. Thank you for coming. I was going to say, thank you for having me in New York, Kameelah. No,
thank you for having me.
Thank you for tuning in to The Resilience Factor. If you're ready to build a stronger, longer-lasting body, make sure to subscribe and share this episode with someone who's ready to thrive. You can follow me at Dr. Pamela Mehta for more expert tips on strength, recovery, and orthopedic health. Until next time, stay strong, stay smart, and stay resilient.